Good afternoon and welcome to the talk on the pericardial disease. First half will be on echo and the second half will be on the CT-MR's role in pericardial disease. So pericardium is very benign when it's healthy. Most of us don't even notice it on echo when it's present, right? There are two layers. There is the parietal area and the mesothelial area. And it is essentially, between these two layers is a potential space. Most of the fluid is in the AV groove and the intraventricular groove. And it can accommodate up to 50 cc's pretty comfortably. The diseases of pericardium are the acute pericarditis, and I'm not going to spend a whole lot of time talking on that. And the ones that we see most frequently, the pericardial effusion, tamponade physiology, the constrictive pericarditis, which always remains a very challenging diagnosis, pericardial masses, and of course, congenital absence of pericardium. The main thrust of the echo talk is going to be on the pericardial effusion, tamponade, and constrictive pericarditis. Acute pericarditis is a clinical presentation where we have patients with classic pleuritic chest pain. And then we look for the classic EKG changes. We look for supportive diagnosis on echo with a presence of pericardial effusion. But there is a big and growing role of cardiac MRI in defining acute pericarditis, particularly the inflammatory component, and help guiding the treatment, especially so in recurrent pericarditis. And I'll leave that to Dr. Nabi to discuss that. What are the advantages of echo, which is very well known? It's portable, it's readily available, it can be done bedside. Most importantly, it gives great hemodynamic data, especially in patients who are unstable. It's relatively low cost compared to the CT and MR. And we have the ability to use TEE as an adjunct in patients who are difficult to image, particularly the post-op patients. Well, there are obviously some disadvantages. And the disadvantages is the field of view is narrow. We can't see much beyond the cardiac silhouette. There is the availability of the window. So if patient is post-op, patient has COPD, the quality of imaging remains poor. And obviously, there is limited tissue characterization, and that's what I was alluding to earlier. Ability to determine pericardial thickness, ability to determine if there is inflammation present remains limited on echo. However, it does remain the first line of imaging in pericardial diseases. And let's look at the echo and what is normal. So before we know what is abnormal, it is incredibly important to know what is normal. And these are your classic parasternal views of the pericardium. You see this bright echogenicity that follows the ventricular demarcation well, and here in short axis. This is your normal pericardium. You see the beautiful sliding of the RV in the pericardial space. And obviously, what are the confounding echoes that we see that can affect how we know whether there's a pericardial effusion, there's a pleural effusion. And so this is a classic example of an echolucency, which is present posteriorly. What is that sound? Pretty irritating. And this, for here, I want you to focus on this echolucency, which is circular. This is the descending thoracic aorta. We frequently use this. I think you guys need to figure out what's the echo. Maybe if I keep away. So there is this echolucency here. And you see this echolucency here, and there is this circumscribed space. This is a descending thoracic aorta. Typically, your pericardial effusion will end before the descending thoracic aorta, whereas the pleural effusion will extend further. Two other entities that can mimic effusion are the descending thoracic aorta, which runs long in the short axis view, and the epicardial fat pad. The causes are well known: the viral postoperative connective tissue disorder, and then the uremic myxedematis you see, and the rarer primary or secondary malignancy trauma. What is very important to understand that what determines the tamponade physiology depends upon the compliance of the pericardium, as well as the rate at which there is accumulation of the fluid in the pericardial space. And the key operational factors here are the reduced cardiac inflow due to the compression of the cardiac chambers, and this, I'm talking about tamponade physiology, progressive decrease in diastolic compliance, and ultimate equalization of the diastolic pressures in the cardiac chamber and the pericardium. And this graph, as you can see, shows it nicely. Here you have on this the pericardial volume and the pressure. And you can see when volume builds up slowly, it is able to accommodate for a large extent before the pericardial pressure starts going up to the level of cardiac tamponade. We see that frequently in uremic pericarditis. And here this is, say, post-op or traumatic acute accumulation and rapid increase in the pericardial pressure, and you enter the tamponade physiology here. Again, this is a graph showing the decrease in the cardiac output, increasing LVEDP, RVEDP as the volume goes up, and the inspiratory changes that we would see in the systolic atrial pressure. So the 2D echo findings: echolucency in pericardial space, early RV diastolic collapse, late diastolic right atrial collapse, and then, of course, the LV diastolic collapse that is present in some cases. Localized connection can have a profound hemodynamic effect. That means you have to understand this, that the chamber that is most vulnerable to a cardiac compression from increased pericardial pressure is going to be the one which is at the lowest pressure in the cardiac cycle at that time. And secondly, if it is sitting, if there is a collection right over the cardiac chamber that is compressing it mechanically. And then we also use contrast, and in contrast, sometimes we have had good luck in post-op patients where we have actually picked up signs of active bleeding as the pericardial space lights up with contrast. And of course, the IVC plethora. We know the quantification of pericardial effusion, mild, moderate, large, and the fluid that is present with each one. And then, of course, the Doppler and the M mode. The classic respirophasic findings in the mitral and tricuspid inflow, the septal motion and the ventricular dependence, chamber collapse on M mode are very important because M mode has a very high temporal resolution. So what sometimes eyes cannot appreciate on 2D in a subtle RV diastolic collapse, you're going to pick it up on the M mode. I'm going to spend 2 minutes talking here about the physiology of the decoupling of the intrathoracic pressures from the intrapericardial pressures that occur both in the cardiac tamponade physiology as well as in the constrictive pericarditis physiology, and as well as the ventricular interdependence. So normally what happens? Normally when you take a deep breath, when you inspire, there is decrease in intrapleural pressures by 5 to 7 millimeters of mercury, and this is transmitted to the intrapericardial pressures too. And with decrease in the intrathoracic pressure, you have increased venous return from IVC, that is most nicely seen, and you will have increased RV diastolic filling. Now, you are going to have slight septal movement, and in inspiration, the venous pressure gradient, because of decrease in the intrathoracic pressure, you're going to have pulmonary vein pressure drop, but at the same time, you're having a concomitant drop in the intraatrial pressure. So you're still having a driving gradient on the left side between the pulmonary veins and the LA, and you're going to see a normal inflow. Now, this decoupling of the intrathoracic pressure and the intrapericardial pressure that occurs in tamponade physiology and in constrictive pericardia, it occurs because now the pericardial space is becoming filled either with fluid or is becoming rigid. And there is this decoupling that happens. Now, no longer are the decline in the intrathoracic pressures with inspiration being transmitted to the cardiac chambers. And therein lies the physiology of the respirophasic changes that we see both in the cardiac tamponade and in the constrictive pericarditis, but with some differences. Any questions? All right. So as I had mentioned earlier, this is a picture that I stole from one of the journals, and it shows a beautiful M mode. And because the M mode has higher temporal resolution, you're seeing a beautiful ventricular dependence. With inspiration, in the during expiration, you're seeing the LV volume increase, and post-expiration, in expiration, you're seeing it increase, and after inspiration, you're seeing it decrease, and you're seeing reciprocal changes in the RV volume. As I mentioned again, this is what I already talked about. And this is the first case. This is a patient who we are in the echo lab. We see this echo, and we are looking at it. You can see there is echolucency and collection of fluid around the cardiac chamber. This is your descending thoracic aorta. The fluid stops right before it, so you know this is a pericardial effusion. Again, you're seeing it in short axis, and you're seeing how it nicely tracks the cardiac silhouette here. This is a pretty large effusion. Again, in this view, you can see fibrinous stranding. You're seeing the LV function is a little depressed. And then you're seeing the classic findings here of variation in mitral inflow. Unfortunately, we don't have a great respirometer, and the patient is pretty tachycardic, but you can see there is more than 25% variation. So what are we looking for? When we measure the peak E velocity at tip of the mitral leaflets, we want to see that with inspiration, there is 25% decrease in the peak E velocity to meet the criteria of increased pericardial pressures. On the right side, which I don't have here, you want a variation of more than 40% for it to be significant. So with inspiration, you will have increase in peak E velocity across tricuspid valve, which would be greater than 40% in expiration. You see IVC plethora, and here you're seeing the sniff, and you're not seeing much change. And you are going to try and get a respirometer and a Doppler with the IVC here. In tamponade physiology, you're not going to see much change. You are noticing some variation, respiratory variation, increased flow with inspiration. We don't have a respirometer good here. But you're not going to see another classic finding of constriction that I'll come to later. Again, views are very important. In the first view, we did not notice the RV collapsing at all. But in the subcostal view, you can see the beautiful RV diastolic collapse. So again, echo multiple views are necessary for us to determine if there is a hemodynamic compromise. In this is another patient with most of the collection anteriorly. There's also posteriorly, but you can see beautiful in the short axis view RV diastolic collapse. Again, in this view, I want you to look at this patient in the apical fourth chamber, and you are seeing a very wriggly motion of the right atrium. Now you have to understand, and you have to slow it down, it's pretty tachycardic, to know that you have to differentiate atrial kick, where the atrial actually contracts, from a late diastolic atrial collapse. And you would have to slow it down and time it. There is a subtle, if I can slow it down. Okay. So, okay, if we can phase it, you see the atrium come in, go out, and then come in again a little bit. But it is not staying for most of the time in the late diastolic period, but there is a subtle finding here. And again, multiple views are important. In this particular view, you can also see RV is struggling in the mid to distal part to expand. Again, the respirometer findings with inspiration at the tip of the mitral leaflet, you're seeing decrease in velocities and increasing in expiration and reciprocal changes across the tip of the tricuspid leaflet. Later, you will also find, as the patient gets more hemodynamically compressed, you're finding that LV outflow is also decreasing, and this is your CW at the aortic valve. And you can see, again, respirophasic changes with inspiration decrease in the cardiac output, which would be manifested as pulsus paradoxus clinically. I wanted to show this case because of the beautiful M-mode finding. Even though if you didn't have this image where you see really the RV just caving in, you can see beautifully here the collapse of the RV in diastolic phase. You see the RV just coming in beautifully. Now, this was an interesting patient. This is a young lady, 54-year-old woman who was hypotensive, tachycardic in CCU, and a stat echo was done. And as you can see, there is a collection both posteriorly, and there seems to be here a RV that is not expanding fully, and there seems to be echo density over the RV. When we plot the CW, we are really not seeing RV diastolic collapse. All you're seeing is a flattening of the free wall of the RV here. Again, you're seeing a collection anteriorly, posteriorly. Again, you're seeing it here anteriorly with the lateral echo density. Again, LV function is not the greatest. No evidence here of the RV free fall not being compressed. Again, emphasizing the multiple views required to determine the tamponade physiology. We didn't have a respirometer on this patient, and this was the only sweep speed available. And you see there is no significant variation, but again, the sample size is very small. So technically, for the technicians, you would want more sampling and change in sweep speed with a respirometer. I chose this case for showing you is because when we gave contrast, you see contrast light up in the pericardial space, indicating there is collection of blood, possibly a leak somewhere. Again, that's an interesting case for you all to see. I'll call on the first year. Who's first year here? No hands going up, no first year. We only have second years and third years? All right, tell me, what do you see? Anything catches your eye. No senior fellows, they are too experienced. Just tell me what you're seeing. Just read how you would normally read this echo.
Is there something that catches you?
There are a couple of things. Okay, any senior fellow? Okay, just go step by step, okay? What do you see? Let's start from the top. You mentioned a collection circumferential. How does the RV look to you? Big, function? I mean, the standard stuff. What is the function? Is it great? Is it not so great?
Very poor.
Okay.
Big and very poor, that's what they say.
Okay, and LV? Hyperdynamic. Okay. Anything in LV strikes you? Maybe you may want to look at it again. Okay. One thing that catches you is this motion of the posterior lateral wall here. And again, as I mentioned, that sometimes our eyes cannot pick up because of the temporal resolution. You can feel there is a funny motion there. And if you were to slow it down and do frame by frame, you may be able to appreciate it better. So let's go to something that has more higher temporal resolution, the M mode. Now, this is real life, so we are going to look at it. This is your QRS complex. With systole, you see the posterolateral wall going in. With diastole, it is coming out. And then again, it is going in again. This is a subtle LV diastolic collapse, okay? Now, the question you have to ask yourself is, why is the LV collapsing before RV? And I had mentioned earlier that the chamber that is most vulnerable to being compressed is going to be the one which has the lowest pressure, so diastolic phase usually for the ventricles, and which has got, relative to the intrapericardial pressure, the lowest pressure. So here something suggests, are the RV pressures too high? Does this person have pulmonary hypertension? And sure enough, you have your D-shaped flattening of the septum. You have your huge RV here, which is hypokinetic. And again, here you can see the free LV wall coming in diastole. You have respiratory variation. It's more subtle here. Again, it shows that you have to look at everything and the sensitivity of various modalities to determine tamponade physiology. This is our TR pressure, TR jet, and you can look that the PA pressure is 60 plus whatever is the RAP. So in this case of pulmonary hypertension, it is the LV which is more vulnerable to diastolic collapse. Now, this is an example, and if anybody wants to take it, first of all, what echo view is it? What modality it is? Anybody? Okay, it's a TE, right? Somebody said TE. So this is a patient who is post-heart lung transplant, hemodynamically very unstable, and you are called to do, assess the patient with echo. The tech goes there, they're very poor images, you can't see anything. So we drop a probe, the TE probe, right? This is the beauty of echo, we can do things bedside. And what you see here is, there is a echo density here. This is your LA. This is your pulmonary vein coming in. This is your mitral valve. And what you're seeing is a compression here from this, what obviously looks like a collection of blood, hematoma, of the LA and the pulmonary vein. I'm also concerned about echo density here over the RA. They put in the flow, and you can literally see the pulmonary vein collapsing here and here. So this is real life. This is what you get. You don't get these pretty pictures that you sometimes see in nice journals. This is what we see when we go to see a hemodynamically unstable patient. Again, the role of TE in assessing this patient who is hemodynamically unstable. Moving fast to constrictive pericarditis, again, rigid pericardium, decoupling of the intrathoracic intrapericardial pressure, ventricular dependence is greatly exaggerated. So what are the 2D findings? You're going to have, if you have to, the classic comparison is between always restrictive cardiomyopathy and constrictive pericarditis. But in clinical scenario, you're going to see this patient present with right heart failure. So often mistaken for liver cirrhosis, ascites, florid pedal venous congestion. LV function is usually preserved. Now, this is your classic patients. Remember, you can have patients who have had bypass and has had surgery and poor LV function and has developed constrictive pericarditis. So everything is with a caveat. You see diastolic septal bounce, low sensitivity. Now, the sensitivity is low because often conduction abnormalities, RE pacers can give us similar motions and have been fallally implicated, but very specific if you have it. And of course, the respiratophasic motion of the intraventricular septum. There is a great paper from the Mayo Clinic by Dr. O that has looked at various indices and the sensitive specificity in a small group, again, a single center study, but 130 odd patients who had pericardiectomy for constrictive pericarditis. And what were their echo findings? So going back and looking at what were the echo findings that best help predict constriction versus patients with heart failure and severe TR. And they found that respiratophasic motion of intraventricular septum was pretty sensitive in picking up constrictive pericarditis. Tethering of RV fee wall, flattening of the LV posterior wall in diastole, I missed my A, and IVC plethora. So why is the flattening of the LV posterior wall? You have to understand what is happening in constrictive physiology. In constrictive physiology, your mid to late diastolic flow is being limited. So early diastolic flow is excellent. The LV relaxes, you have boom, sharp E wave, rapid deceleration, tiny A wave, because now there's no room to accommodate more. So the findings that you see on the echo are reflective of the physiology of constriction. And therefore, you see the flattening of the LV posterior wall in this, because now nothing is coming in. The classic findings which are present at mitral inflow, deceleration time, isovolemic relaxation time, all are decreased. But this can be also present in restrictive. What is not present in restrictive cardiomyopathy is the respirophasic variation. And again, the presence of pulmonary edema clinically is more common with the restrictive cardiomyopathy. So Doppler findings are respiratory mitral inflow variation, diastolic, but you can see this variation in many things. You can see it in tamponade, you can see it in COPD patients, you can see it with RV failure. So they are not very specific for constriction. Diastolic reversal in expiration in hepatic veins is a very pathognomic feature of constrictive pericarditis when present. And there is a ratio of forward flow to reversal that you can do. And if it is more than 0.79, it is highly specific. Then we come to the tissue Doppler findings. And there are a couple of the terms annulus reversus and annulus paradoxus. So let's see what it means. Now, typically, you're going to have medial tissue velocity at mitral annulus in constrictive pericarditis better preserved than the lateral free wall, which is tethered. So you're going to have a E prime of greater than 9 centimeters. It is considered very specific. And your E at medial annulus is greater than at lateral annulus. And this is called annulus reversus. Ratio of greater than 0.91 in that paper was also very specific for constriction. And lower E to E prime ratio in setting of increased LV pressure is called the annulus paradoxus. So you have restrictive filling pattern at mitral inflow, and now you have excellent relaxation relatively present, indicating there is no cardiomyopathy here. And that is called the paradoxical finding. Now, this is the paper that I was talking about, and I want you to focus here on the sensitivity specificity. So they looked at 5 things: ventricular septal shift, change in mitral E velocity, medial E velocity, medial E prime and lateral prime ratio, and then the hepatic vein ratio in expiration. And as you can see, the most sensitive was the ventricular septal shift. Not most specific, but great positive predictive value. What they then did was say, okay, let's combine and see. And when they combined, they was getting more specificity, especially when they combined it with the medial velocity and the hepatic vein expiration ratio. They're getting more specific, but the sensitivity was dropping. And so if you use it in a case where you have respiratophasic septal motion, you have a E medial velocity of greater than 9 centimeters, and you have a expiratory diastolic reversal, you're going to be very specific for constriction if you have all those 3. Obviously, in all constrictive pericarditis, you're not going to have all present. Interestingly, obviously, the respiratory variation was not found to be independently associated with constrictive pericarditis in this small single standard study. I want to also mention briefly here that the etiology of constrictive pericarditis also affects the findings that we have. So the classic findings that we discussed earlier are very much present with the idiopathic or post-operative cases. It drops to some extent, and then with radiation, we really enter into a difficult zone. The reason being, with radiation, you're going to have a combination of restrictive cardiomyopathy and constrictive pericarditis. And therefore, you're not going to have your classic findings that you see of respirophasic variation with the ventricular septal shift. Now, going into case, this is a young man who had bacterial pericarditis, HIV positive, and I just want you to show the classical, what your eye can pick up, that you feel that there is a funny motion of the septum. You feel here there is some echo density, maybe some thickening, but not very clear. This is your classic. In this patient, we did the mitral, M mode, and here I honestly would love to show you the wriggling of the septum, but I'm not able to show it to the best resolution. This is a textbook picture, which we sometimes see. With inspiration, you can see the septum is moving, the ventricular septum is moving towards the LV. Then you have this little wriggly motion, which is called the septal shudder. And the septal shudder, or septal diastolic bounce, is seen in a beat to beat. So it is not just related to inspiration and expiration, but you're seeing it with every beat. And this is due to the timing of the RV filling and LV filling being different, and the mitral and tricuspid opening time. So you see what is called a septal shudder. It is pathognomic of ventricular dependence. And then again with expiration, you see the septum moving. Where is my beat? Okay. So this is your classic septal shuddering. With inspiration, septum moves here. With expiration, now you're seeing it move back. Again, you can see the septal bounce here, seen here. This is your classic finding. This patient had, this is your mitral annulus here, and the tissue Doppler velocity. You can see E almost reaching up to 15. And this is your lateral free wall velocity, and it is less at 10. So this is your annulus reversus. Mitral inflow variation. With inspiration, you're seeing decrease. With expiration, it starts coming up. You also have LV outflow variation that is present. Again, IVC plethora and little reversal you can see by color. This is your respirometer. A good attempt was made here to get it. And you can see that with expiration, there is some decrease in forward flow, but I cannot conclusively say that there is an increase in reversal here. Your classic picture would be, textbook again, would be something like this. With inspiration, you see the flow increase, but with expiration, you have decrease in forward flow, and there is a reversal. And this ratio, if it's greater than 0.79, is also pretty specific for constrictive pericarditis. This is a real-life patient who, and I want you to, I'm going to be really, should I stop, Faisal? Okay, really quick. Really quick. This is a real patient who came in. I want you to see this echo because you see lovely. No fake patients. No fake patients. But this was a very classic case in how the studies evolve, how the physiology evolves. So patient had, you can see a little calcification here of the aortic valve. You see LV great function, no abnormal septal motion. Aortic valve looks calcific. Again, short axis, beautiful motion here. And patient has severe aortic stenosis. I got the samples that I could showing, the E and A transmitral, nice IVC collapse. Patient undergoes aortic valve surgery, has a large collection here, and you can see a little bit of a funny motion of the posterior vault here, but yeah. So patient undergoes, okay, we are still seeing it, and you can see it here also. And I've tried to show you there is a little bit of upward motion you can see here in diastole of the posterior wall. And that is LV diastolic collapse seen here. You can see the respiratory variation. Patient undergoes pericardiocentesis. Again, you can see variations in the no respirometer here. And I'm trying to see if I can show you anything. you can see there is a phasic change, increased flow and reversal, but I don't have a respirometer to show you where it is. So patient undergoes pericardiocentesis, and now all you see, there's no effusion, LV motion is now normal, except for the septal motion. And again, you feel that patient may have a septal bounce, but there is a pacemaker wire present here. They didn't do the change the sweep speed or put a respirometer, but on tissue Doppler, this is your septal E, velocity is high, and your lateral E velocity is low, indicating possible tethering of the lateral free wall with constrictive physiology. This is 5 months follow-up of the same patient. Now he has a prosthetic valve. And you see the paradoxical septal motion is not that the bounce is no longer present, even though the pacemaker wire is still here. And you see resolution of the annulus reversus. That is, your lateral E velocity is now around 10 plus, and the septal V velocity has decreased. So thank you very much, and that is.
Okay. Okay, thank you, Gopi. That was awesome. Good afternoon. I will be talking about CT and CMR and how we can apply it to pericardial disease. So just some introductory slides. Echo is the first-line test for this modality. However, there are some limitations which we are all aware of. It can be, in my opinion, very, very hard to see the pericardium with echocardiography. And then depending on windows and whether an effusion is loculated, you can have difficulty there as well. So is there a role for these advanced imaging techniques, CMR and CT, in this disease process? And I would say definitely yes. These are techniques, as you know, that have a very large field of view. We're able to image the entire heart, the entire pericardium, the entire thorax. You can freely choose between imaging planes. Both techniques have exceptionally high spatial resolution and can really show you the pericardium in great detail. Now, when it comes to choosing between these two modalities, really both, as we had said, are both excellent for anatomy. Where CMR can really add value, of course, is when it comes to assessing physiology, because we have that aspect of it, and then also in the assessment of inflammation. CT is an absolutely incredible technique for preoperative planning and whenever you're looking for calcification in the pericardium. And as we go through the talk, hopefully I'll hit on all these points in detail. So just a little bit about how we image the pericardium. I'll start with both CMR and then mention both techniques. With CMR, we use what's called a T1 weighted spin echo sequence. You can see here that we can see the entire thorax, we can see the entire heart, and we can image the pericardium in multiple different views. The pericardium, I hope you'll appreciate with the arrows, is this very thin, hypo-intense structure that goes around the heart. What you'll notice is that you can really see it well, usually anterior to the RV, and this is because that's where it's surrounded by fat, and you get that difference in tissue contrast. And it can be particularly harder to see whenever on the infralateral portion of the LV, and that's because, again, there's less fat present. And normally, as you'll see in some slides coming up, there's usually some amount of pericardial fluid there, generally in the order of less than 50 cc's. Contrast this with, hopefully, with this image, where I hope you'll appreciate a very thickened, rind-like pericardium completely circumscribing the myocardium. And here we consider an abnormal pericardium usually greater than 4 millimeters thick. Now, what about CT? CT, of course, is also a tool that has the highest spatial resolution, so should therefore not have any problems visualizing the pericardium. Main points of these slides is, again, I hope you'd appreciate that you see the pericardium the best anteriorly over the right ventricle, again, because it is surrounded by fat there, so you get this natural contrast between the two tissues, and less so in the infralateral LV wall. And I hope you'll also appreciate that that you can look at the pericardium both with and without contrast. So if you just want to know about the pericardium, you really do not have to administer iodinated contrast. As Gopi alluded to, this is really a spectrum of disorders. I'm going to hit upon all of these a little bit on each, spend a little bit time more on some than others, and we'll keep on going. So let's start with pericardial effusions. This is a great technique because you're able to, using our axial, sagittal, coronal views, we can really look at the entire circumference of the fluid. It's very easy for us to differentiate a pericardial fluid from a pleural effusion, from ascites. I know sometimes with echo imaging and windows, it can be a little bit challenging. You can see with this technique, because you're imaging the entire thorax and maybe even also the upper abdomen, you really have great ease in differentiating structures. Another thing that's very important is, of course, when it comes to loculated effusions, these are great techniques because you can really assess the full, exact location of it. What's more is that at least with CMR, we can one of the problems often becomes is differentiating between fluid and a pericardium. Both can look echo-dense by, hypo-intense by echocardiography. And with CT, you often have a merger of the tissue intensities, and they can almost look exactly the same. I'll show you a case of that. But where CMR is helpful is, of course, with tissue characterization. So we don't have difficulty or as much difficulty in differentiating pericardial fluid from pericardial thickening. And this is a good example. If you remember the first case I had shown you, if you look here in the spin echo, you see this very dark rind around the heart. You get worried, is this a pericardial thickening? But the way we figure it out is by actually going to another sequence called an SSFP sequence. This is a sequence we know that anything very bright is usually fluid. So this darkness that we're seeing here, that tells us this is not pericardial thickening, but rather this is a pericardial effusion. So just pointing out that using tissue characterization is much easier with CMR and can help us differentiate thickening from actual fluid. Now, we can go a little bit further with both CT and CMR.
Faisal, how about if you have a lot of inflammation in the pericardium? T1 would be up too, right?
Sir?
If you have a lot of inflammation in the pericardium, acute pericarditis or whatever
Yes.
it is, it's gonna have the same signal, no?
Yes. I'll show you some images. It actually becomes a lot easier when the pericardium is inflamed because we have a whole bunch of other sequences. We have T2 imaging, which allows us edema imaging. You can see the pericardium very nicely. I'll show you some images. They'll become clear. So with CT and CMR, again, not only can you localize the effusions very well, but you can even tell the physicians a little bit about their consistency. Usually transudative fluids are very bright, as we had said in SSFP sequences. You can see that. Whereas if you look at an exudative process, you can see this very dark-looking fluid. And, we have other ways to figure things out. Usually signal intensity on T1 spin echoes increases as you get into an exudate. And on T2 weighted images, you have a decrease in signal intensity. So we have a little bit of tricks that can help us figure it out. CT can also look at the pericardium very nicely. This is two examples of looking at one case with just pericardial thickening and another case with pericardial thickening with fluid. So I'm sorry, just with a pericardial effusion. So here's a case just with pericardial effusion. So you can see that here anterior to the RV and posterior laterally. Here you can see, you have a pericardium. You're helped a little bit because you have a little bit of contrast in the pericardium, and you may have some surrounding fluid with it. But I hope at least by this slide you can appreciate that, at least for people who have, are learning to read CT, this can be a little bit difficult. differentiating between pericardial thickening and pericardial effusions. And only because tissue characterization can be a little bit more challenging.
Is there any data on different Hounsfield units to differentiate between pericardium?
Yes, sir. So on this slide, we definitely measure Hounsfield units on whatever we see, and generally transitive fluids will have less than 10 Hounsfield units. Water is 0, so anything close to water will be transitive, whereas exudative fluids will have generally 20 to 60. But you can see there's quite a range. And whereas acute hemopericardium is more than 60 HUs. So let me show you a case, just showing you some of the difficulties often with CT. Here's a case. I want y'all to just look at these images. And this was a 23-year-old, comes in, HMH, nausea, vomiting on her CT. Echo showed a mildly, so she gets a CT for that. They happened to scan a little bit high. I guess she was having some symptoms in her chest as well. Echo comes back with a depressed ejection fraction. So I'm going to let this play one more time. Hopefully it'll play. And anybody see anything striking they want to call out? Well, there is definitely fluid right here, so I think we'll point that out. And when this movie plays again, I want you to look anterior to the right ventricle. And, you're a reporting physician, you're reading CTs with us. We're going to have to make a comment on this, right? So this was read out as a pericardial effusion. And I think most people would say, okay, it seems very reasonable. You got a pleural effusion, may have a pericardial effusion as well. So because of the cardiomyopathy, this patient was sent for CMR. And I hope you can see now very clearly here, with the RSSFP images, you have fluid that's very bright. Whatever was on top of the RV is not fluid. So this is just a great example of where, tissue characterization with CMR is just a little bit easier than with CT. And actually, this turned out to be a right atrial sarcoma, 23-year-old female. So, very, very important. So every now and then, it's not common, and neither do I recommend this test, if you're trying to diagnose this condition. We get a patient in our scanner who has cardiac tamponade. You have to be very aware of the signs and symptoms, at least the the MRI findings of this. This is the right atrial notching, right atrial systolic collapse that Gopi was mentioning. And usually if this is more than 2/3 of the cardiac cycle, it's significant. Obviously, you want to show also impairment of hepatic and pulmonary and systemic venous pressures. What about with CT? CT will also show you signs of cardiac tamponade. What are those? Usually you'll see a flattened heart. You'll see elongation of the ventricles. You'll see elevations of systemic pressures with dilation of the SVC and IVC, reflux of contrast into the hepatic veins. Okay, so we'll move on to the next disease process. One of the conditions where I think we may underutilize CMR is in the diagnosis of acute pericarditis, and I'll tell you why. So as you know, there are 4 criteria, and you need 2 out of 4 in order to make the diagnosis of acute pericarditis. This includes positional chest pain, a pericardial rub, new ST elevations or PR depressions, and the presence of a pericardial effusion that's new. Now, all of these have problems. Most of the time, patients will give you a typical chest pain history, but we all know pericardial rubs can be fleeting, or you may have difficulty hearing it in the emergency room. We also know EKG changes can be temporary or fleeting. And then a lot of times, most hearts have a little bit of effusion. So if you see a little bit of effusion there, is it something new or significant? So it can be a little bit difficult. So how can we, add value with some of these other techniques? Well, here was a case, 48-year-old, positional chest pain, physical exam normal. He didn't have any rub. EKG really showed what I thought was early repolarization. I didn't feel there was any PR depressions or ST elevations. And echo did not document an effusion. If you look at this heart, I hope most of y'all will agree that, at least in these images, you see something here and anteriorly. And if you look a little bit further, you may see something here laterally, and you see it's more here anteriorly. Well, this is thickening of the pericardium. It definitely is not the typical fluid that I had shown you. But this was where, Dr. Zogby was alluding to, how can we use CMR's tissue characterization to go further? So our turbo one-spin echo shows the pericardium very nicely, and you can see right here that this is a rind-like thickened pericardium all around the heart, and you can see it very nicely. But what's also nice is we have a technique called T2 imaging, which is water imaging or edema imaging. So we can actually look at this pericardium with our T2 imaging, and I hope you appreciate this brightness. Any brightness here indicates active edema or water. And this edema or water in the pericardium is very is consistent with pericardial inflammation. We can support that further then by looking at our post-gadolinium sequences. Any post-GAD sequence here, specifically LGE, what y'all are used to seeing. And I hope you'll appreciate just all around the heart. Very easy. You can see it from back of the room. The heart is circumscribed by a white layer. That white layer is, gadolinium uptake in the pericardium, indicating active pericarditis. And if you look at this vibe sequence here, it also shows you, that you should not have this white sac around the heart, as it'll play again. If it'll play again. Okay, here we go. All of this white sac you see is just diffuse inflammation of the pericardium. So, there's now been 2 abstracts. I try to find them in publications. They have not been done yet, but I think they're good. I'm not sure what the holdup is. Basically, the first one showed that of patients who have had a negative ischemic workup, almost 10% of patients have acute pericarditis. Those who had negative workup and went on to have CMR, 10% have evidence of active pericarditis. So you go from, not having a diagnosis from your patient to 10% being able to diagnose your patient with a disease process that can be treated. Furthermore, the second abstract showed that, that 10% who have active pericarditis tend to be younger in age, which, is not surprising. Okay, and this was the same patient, same heart that I showed you post-anti-inflammatory treatment. I hope you'll appreciate the pericardium now is completely thin. You don't see it, and there's no more that bright white enhancement around the heart. Dr. Marion, there are CT images coming. Okay, so this is also a very nice, example of pericarditis with effusion. And Dr. Zogby, I hope this answers your question. Here you see effusion, and when you do this, imaging here, you can appreciate not only you see the effusion here is black, but more importantly, you see hyper enhancement or brightness in both the visceral and parietal pericardium. So it's a very nice example of having an effusion with concomitant pericarditis. Okay, so CMR can be even more helpful. We know patients can have concomitant myocarditis. You have this thickened pericardium that's rubbing against the heart, and usually in the subepicardial layer of your LGE images, you'll see some delayed hyperenhancement, and now you've diagnosed them with another disease. So, there are a lot of reasons you should consider active pericarditis for acute pericarditis. I would say whenever you don't have a diagnosis, if you have ongoing symptoms, continued fevers, not good response to therapy, or in the setting of trauma. Okay, so let's move on to another disease process. Now we're moving to more of the chronic stage. So this was a case, 47-year-old. She had a bunch of interesting diagnoses, AT3 deficiency, APLA positive, factor V Leiden, denied any known rheumatoid arthritis or lupus. She presents with 7-month history of progressive dyspnea on exertion, lower extremity edema, fatigue, and right upper quadrant pain. With inspiration, her GVP increased. I didn't appreciate her rub. She did have a big liver. She had swollen legs. Legs were normal. You look at the echo, and Gopi did a superb job. She had everything Gopi talked about. Restrictive filling with respiratory inflow changes, annulus reversus and annulus paradoxus, hepatic vein expiratory diastolic flow reversal, and a septal bounce on the images. So diagnosis is pretty clear, constrictive pericarditis, both by history and then concomitant echo findings. So my question to you is, what would you do next? And we won't go around the room thinking, but, would you send this patient off straight to pericardiectomy? After all, they have signs of right heart failure and they have active constriction, right? That is the treatment. Well, hopefully by the end of this, I will convince you to consider CMR first. And the reason is why. Let me show you this case. So this patient had a CMR done, and this was the heart here, and we'll get into, I just want to demonstrate what the CMR findings of constriction are. So first of all, morphology. You can, with CMR, look at the pericardium. So with our turbo 1 spin echoes, I hope you can appreciate now, I've shown you many examples of this, a nice thickened pericardium all around the heart. But there's more morphology that we can do, right? We need more now physiological proof that this is actually doing something. But in general, again, more than 4 millimeters is, in the proper setting, is diagnostic, especially if it's 5 to 6 millimeters. So here was the non-contrast CT of this patient. Just, I'm bringing in whatever image so you can see how this process looks with different techniques. And it's the exact same as you would expect, this rind-like process around the heart. What other morphological features do we look at before we get into? What else can we see? We can look, just like Gopi had mentioned, you have impairment of system. Remember the three things in constriction, most important things. You have dissociation of intrathoracic and intrapericardial pressures. You have ventricular interdependence or ventricular coupling, and you have impairment of filling with equalization of pressures. So you can actually look for all of these things in your images. So we have, if you're systemic and pulmonic venous, you'll have systemic and pulmonic venous hypertension. So you can actually see IVC plethora and a failure of collapse with the inspiration. You can see an enlarged RA. Remember, the right side is these patients mostly have right-sided symptoms first, because that's the side with the lowest pressures, as Dr. Shah had mentioned. You can see pleural effusions. You can see the hepatomegaly. You can diagnose the ascites. So you can have a lot of other morphological findings that you can do. But the beauty of CMR is it's also a technique with physiology similar to echocardiography. So we can show a lot of the same things that the echocardiographers can do. We know one of the signs of ventricular interdependence is what Gopi was talking about, the septal flattening or the septal inversion, where in very early diastole, with inspiration, there's a moment of time where the right-sided pressures are higher than the left, and you have a leftward shift of the septum. It makes it looks like this S-like motion that you can see. Furthermore, even better than that is what we have. We have a real-time sequence where we can actually watch the left and right ventricles simultaneously as they fill and expel blood. And what I hope you'll see here, this is this patient free breathing. And I hope what you'll see is as this diaphragm drops, the patient has inspired. And what happens in constriction? Filling increases on the right side. You have a fixed sac. It occurs at the expense of the left, and the septum gets shifted to the left. And if you look very closely, when this diaphragm drops, you'll notice that leftward shift. And it's so subtle, I made a enlarged picture for you. And this, as Gopi had told you, is a very, very specific finding because it demonstrates ventricular uncoupling. We have another technique called tagging sequence, where you create these pixels, and it's often on the heart. It's often used for strain analysis. But the idea here is the pericardium and myocardium should move independently. If they're moving together, they're likely adhered and immobile, and it can help you diagnose adherence of the pericardium. There are newer techniques available, such as real-time phase contrast flows. So you can actually demonstrate the respiratory phase changes across the AV valves. And this is just a great example. You can image both the mitral and tricuspid valves simultaneously. You can see the restrictive filling pattern, and you can see whenever with inspiration, you have an increase in velocities on tricuspid valve velocities with a decrease in mitral valve velocities. I didn't realize this, but we can go even further. If you can, we have the ability to do LV time volume curves, and if you see a square root sign, you can make your diagnosis of constriction there. And furthermore, if you look at flows in the SVC, you can see less flow in systole, more flow in diastole. All right, so I hope I've shown you a little bit of tissue characterization with CMR. And, okay, so here is another case. Yes, yeah, it's coming. Okay. So, all right, so this was that same case where you can see, just diffused on T2 imaging. Sorry. All right, so the other trick, we haven't talked, one more power that CMR has, the most powerful power, the ability for tissue characterization. So here we talked about what else is tissue characterization we can do, right? We've got T2 imaging, edema imaging, and ability for late gadolinium enhancement. Here you can see this same patient with the thickened pericardium, as I had shown you before, you have diffuse, a hyper-enhanced signal around the pericardium in T2 imaging. This is edema. This pericardium is actively inflamed, and an LGE takes up contrast. What does that mean? What does the fact that it took up contrast mean? It has very important prognostic information for you, because remember, this is now a case where it's completely changed management. What this means is this patient should be treated with anti-inflammatories. The pericardium is actively inflamed. And let me show you this heart 6 months after anti-inflammatory therapy. I hope you'll notice all the signs of ventricular cupping. The septal bounce has all resolved. The pericardium you can barely see. If you look at tissue characteristics, the pericardium is no longer thick. It's no longer bright white. No, there's no edema around the heart, nor is there any LGE around the heart. So you can use this technique even to follow the course of your patient's constrictive pericarditis. So here's just a pre and a post therapy to make it more obvious to you all, because I know we're all looking at these images not so frequently. Studies have shown what this LGE means. The patients who have LGE and have gone to biopsy at surgery, biopsy shows active inflammatory tissue, neovascularization, granulation tissue, inflammatory tissue. It means inflammation. One study showed that if you took 29 constrictive physiology patients, treated them all with anti-inflammatories and looked at who responded, only those patients who had LGE were those patients who responded. So they're, a very valuable tool that can help you diagnose and how to treat your patients. Contrast that with this heart. Here, I hope you'll appreciate right away from just looking at these images, you have a ventricle that's conical. It's tube-shaped. It's being compressed. What is it being compressed by? Something here, anteriorly to the RV, right? If you look at these real-time images, I hope you'll appreciate there's the diastolic shudder. This was an image just to show you that the IVC was dilated and plethoric. Here was this patient's tissue characterization. On T1 images, we definitely had pericardial thickening here, anteriorly and anteriorly here and anteriorly here. There was no hyperenhancement on T2 imaging, and there was no LGE. So this is not a patient with active inflammation of their pericardium. So they have constrictive physiology, but they're not actively inflamed. This patient went on to have a non-contrast CT scan, and you just see a rind of calcium. This is the end stage of chronic inflammation. So TB is the most common cause of calcific pericarditis, but now in the Western world, 20 to 30% will have idiopathic reasons for having calcification. But a tool to show, another nice way also to emphasize CT is king when it comes to showing you calcium. CMR, it's no protons in there, so you just see a dark signal. So this was a patient who benefit from stripping and not anti-inflammatory therapies. So here's other examples with CT of constrictive pericarditis. We can easily look at the thickening of the pericardium. With CT, we don't have physiology. unless you do a retrospective gated image, but we can look for morphological findings. Morphological findings are these long and tubular in shaped ventricles and signs of elevated systemic and pulmonic venous pressures that include big atria, ascites, pleural effusions, pericardial effusions, dilated IVC. All right, CT can also help you in patients who are going on to the operating room for localizing grafts, making sure what the coronary anatomy looks like. It can be very helpful in radiation-induced constrictive pericarditis. It can help the surgeon know where to cut and where not to cut, and evaluating the coronaries in a low-risk patient. So just a slide summarizing some of the differences between CT and CMR. CT, great again for spatial resolution and calcium. CMR really wins when it comes to tissue characterization, physiology, and assessment of inflammation. Do bear in mind that 20% of patients with constriction can have normal pericardial thickness. Okay, how else can CMR help? This was a 65-year-old patient with some non-ischemic cardiomyopathy who had right heart-sided failure symptoms. Does he have constriction? So in this particular case, the pericardium was intermediately thick on T1 images, but you give LGE, and all of a sudden the myocardium lights up. This was a patient with cardiac amyloid and more likely a restrictive cardiomyopathy for his symptoms rather than constriction. All right, some things that only the advanced imaging techniques can really help you with are when it comes to the assessment of cardiac masses. You should know a cardiac mass in the pericardium is more than likely a metastasis or a secondary malignancy rather than a primary cause. CMR can be excellent for tissue characterization, for establishing a differential, for looking for complications, and assessing, the general morphology of the entire chest. There are some primary tumors which can invade out of the heart into the pericardium. A very big null culprit is the right atrial, the sarcomas. You can see this sarcoma starts in the right atrium and just bursts out of the heart. The thing with CMR that can be very helpful is whenever you have gadolinium uptake, it's always a tumor. So I'm not talking about malignant or non-malignant or benign. I'm just saying whenever you have gadolinium uptake, it is a sign of a tumor. So it can be very, very helpful to you there. It can also help you differentiate other structures that may be in the chest. This was a large pseudotumor compressing the heart. This turned out to be a pericardial cyst. These generally originate from the pericardial surfaces. They're benign. They're usually on the costophrenic angles, right greater than left, and majority are asymptomatic. Here's an example of a pericardial cyst with CT. Notice, again, tissue intensity between the myocardium and muscle, and the fluid, it just has a narrower range of discriminating. But if you were to check a Hounsfield unit here, it would be closer to water. And then let's not, this is Dr. Zogby's patient. Let's not forget, we can also, there's entities, congenital entities of the pericardium, both partial and complete absences of the pericardium. This was an example of a complete absence of the pericardium. Generally, these patients will have a Snoopy dog-shaped heart. That's what this is called. Those of you who have kids, this looks like Snoopy Dog. Because there's no pericardium, the heart is completely shifted over into the left hemithorax. And the pathognomonic sign is that where there's pericardium, where should be pericardium, there's lung, because there's no pericardium there. So you look in the aortopulmonic window, there should be pericardium here. Instead, you see lung. This makes the diagnosis, period. So thank you very much. Please consider the advanced imaging techniques in your difficult patients. And don't forget, this is just published A for pericardial diseases, both with CT and CMR.